Start recording now, and we'll let people come on as they can. So welcome everybody to this week's Medical Biochemical Genetics Fellowship Clinical Course Seminar Series. It's September 10th, 2021, week 8 of the series, and we're honored to have Dr. Manoli come in to talk to us about MMA and cobalamin-related disorders. Dr. Manoli is at the NIH. She's a colleague of Dr. Venditti's, who's going to be talking next week. And we're excited to have both of them here and all of their experience in both research and the clinical setting. It's fantastic. So happy to have you, Dr. Manoli. And I think we don't have any other announcements. As always, these recordings are going to be on the SIMD website, so you can access them there. And as questions come in, they'll be in the chat. Irene, I don't know if you can see the chat or not, but I can call them out as they come, or we can just wait to the end.
Yes, please let me know, because if I share the screen, it covers the whole screen, I think.
Sure, yeah, if anything's pertinent at the time, I can break in, but otherwise I'll not interrupt you and save it to the end.
So great, thank you all. Thank you for coming and joining this lecture today. It is a pleasure to be here and talk to fellows and colleagues on organic acidureas. This will be part 1. I will talk mainly on methylmalonic acidemias and cobalamin disorders. And Dr. Venditti had an urgent conflict today and couldn't make it, so it was kind of a rushed replacement for me. But this is Dr. Venditti and our group at the National Institutes of Health in Bethesda, Maryland. We have a long-standing natural history protocol seeing all kinds of MMA and cobalamin disorders and propionic acidemias. We're here to help you answer questions. Please never hesitate to write or discuss cases or refer patients for a more thorough workup at NIH. Anything, we are here to help the community. So that's Dr. Venditti, our nurses, Jennifer Sloan, our genetic counselor, Dr. Shalokov, our other clinician and director of our fellowship program, one of the fellows that is.
Irene, I think the screen stopped sharing. If you could reshare, I don't know what happened, but.
I don't know what happened. Sorry for that.
It's okay. I think maybe when you shared the link, somehow it stopped sharing the screen. I don't know how that worked, but I'll let you know when there it is. There it is. Perfect. It's back on.
Okay.
And
sorry for some glitch.
Good.
Feel free to interrupt, obviously. All right. Great. So we'll discuss the heterogeneous group of disorders. Are you seeing the faces at the top? No, right? You're seeing my slide only, right?
Yeah, learning objectives is what we're seeing.
Lovely. So we'll discuss disease mechanisms and the treatment approaches: medical, dietary, surgical, and experimental. So what are the hereditary methylmalonic acidemias? It's a group of inborn errors of branch chain amino acid metabolism and intercellular B12 processing pathways, first described in the 1960s. They're detected by tandem mass spectrometry in the newborn screening. The incidence is about 1 in 50 to 80,000, and they're characterized by massive excretion of organic acid, methylmalonic, 2-methylcitrate, acylcarnitine, propionyl carnitine, and they have a guarded prognosis. So in general, food, mainly protein from the food, will be turned to energy. The amino acids that feed to make propionyl-CoA are valine, isoleucine, valine, methionine, isoleucine, and threonine, and then chain fatty acids. We try to say the acronym VOMIT because the children, a very common manifestation is frequent vomiting that leads to catabolism and metabolic ketoacidosis. So the precursors to propionyl-CoA are turned to methylmalonyl-CoA, isomerized to L-methylmalonyl-CoA, racemase and isomerized to succinyl-CoA that enters the Krebs cycle to release ATP. Those are all a mitochondrial process. And the methylmalonyl-CoA mutase reaction is here that causes the classic methylmalonyl-CoA mutase MMA. And then the cofactor for this reaction is adenosine, 5-deoxyadenosylcobalamin, and the enzyme genes that are needed to process the adenosylcobalamin to the methylmalonyl-CoA mutase enzyme is the cobalamin A, MMA product, and cobalamin B, the MMA-B product. And those three are main causes for isolated methylmalonic acidemia. And those two are, so adenosylcobalamin is the B12. B12 comes from the external sources, is uptake, needs to be taken up by the cell. processed in the lysosome and then has several steps in the cytoplasmic compartment to make the two active forms, the adenosylcobalamin and the methylcobalamin. Those are the only two reactions that require B12 in our body systems for the mutase reaction and the methionine synthase reaction in the cytoplasm that produces methionine from homocysteine. A defect early in the pathways causes a combined methylmalonic acidemia and hyperhomocysteinemia with low methionine. And then we have for the isolated MMA, there are more rare forms like the epimerase gene MCEE, methylmalonic CoA epimerase, and then the succinate CoA ligase that there are genes that encode that. It's a Krebs cycle and reaction the ligase from succinyl CoA to succinate. And this is associated with lactic acidosis. And the combined malonic and methylmalonic acidemia, the gene is ACSF3, is an interesting and common defect that is required to produce methylmalonyl CoA and malonyl CoA from MMA and malonate. And then again, this is an even more extended pathway with additional defects, and new defects are being identified recently in this complex intracellular B12 metabolic pathway. Again, the ones in blue here, MAT-MMA, cobalamin A, cobalamin B, and cobalamin D MMA cause a defect here in the mutase step and are the causes for the isolated MMA defects. Propionyl acidemia is the step before the propionyl CoA carboxylase precedes the reaction for the mutase, right? It's here. And then the combined homocystinurias and MMA are of this purple form. Those two, cobalamin F and cobalamin J, are needed for the egress to release the cobalamin from the lysosome to the cytoplasm, and then intracellular steps, processing steps that remove the cyanide from the B12 molecule, cobalamin C, the MMA CHC, and the new defect PRDX1, and then nuclear genes that are transcription factors that regulate the expression of the MMA CHC genes, HCFC1, ZNF143, and FAP11 are also causing combined homocystinuria and methylmalonic acidemia. Those are very rare, and we'll talk more at the end for the cobalamin defects, but I won't point out because that is the only X-linked inborn error in the B12 metabolic pathway, and it's rare to cause a inborn error of organic acidemia, so HCFC1 here. And then the ones in green at the bottom here for the methylcobalamin dependent reaction and the methylation cycle are the methionine synthase and methionine synthase reductase causing cobalamin G and cobalamin E isolated homocystinuria now, and cobalamin D homocystinuria. Again, those are the ones here colored in green. And then the receptor, transcobalamin receptor defects are early on in the uptake of cobalamin to the cell. So that's a very complex pathway, and we'll go through the defects in the next few slides. So all of them are, there was something in the chat, is that, was that a question so far?
No,
it's just a link.
Just your link. I put it up again for anybody just joining.
Lovely. I will, yeah, the link is there for everyone with lectures on the topics. Okay, newborn screening, mass spec based newborn screening started around early 2000s. We get blood from the infants, they go through the mass spectrometer and we read the spectrums, and expanded newborn screening up to 2005, and by 2010 all the states have incorporated expanded newborn screening in the US. This is not the case for many other countries in Europe and elsewhere, but in the US we screen for the core disorders, MAT-MMA, cobalamin A, cobalamin B, propionic acidemia, And then many of these other intracellular B12 metabolic diseases are as secondary targets. Of course, our screening now is expanded to include more disorders, and we are entering an era where exome sequencing will be incorporated and hopefully improve the sensitivity and specificity in addition to the metabolic screens. So new times and exciting times ahead. So newborn screening will pick propionyl carnitine, C3, and then we have secondary analytes, C3 to C2 to acyl-carnitine, methionine to phenylalanine, and decaptanoyl carnitine, C17 are all suggested and discussed as additional markers for this pathway detection. And then the secondary tier measuring serum MMA and total homocysteine is very helpful to make the lead the diagnosis. When you get the call for the high C3, don't forget to check maternal serum B12 to rule out maternal B12 deficiency. And I want to add here to start B12 immediately. Hydroxycobalamin is preferred if available. If not, cyanocobalamin can be used and changed to hydroxy as soon as cobalamin C defect is suspected. But we follow up with urine organic acid, plasma amino acids, and MMA and homocysteine and serum B12. And then very high MMAs and no homocysteine. We have the isolated methylmalonic acidemias, MAT0, MAT-, depending on the degree of enzymatic activity. MAT0 are more severe patients with no enzymatic activity. MAT- are patients that have some residual enzymatic activity. That depends on mutations. We'll talk a bit more in a minute. Cobalamin A, B, and cobalamin D MMA. A few cases will be B12 responsive, rarely, really some MAT- and a portion of cobalamin B and all the cobalamin A, but B12 has to be given immediately to see if we detect a response. So unresponsive forms are MAT0 and cobalamin B. If we have a response to the B12 and we give B12 every day for 5 days and expect about a 50% decrease in the serum MMA, that's kind of the protocol described in the current guidelines. The responsive MMAs are cobalamin, mostly the cobalamin A and some of the other defects. And then a combined MMA and homocysteine, we have the combined defects here. Those are responsive to hydroxycobalamin. And if we have no response, if we have, they are responsive, but they don't completely normalize the homocysteine and the MMA. If they completely normalize, you may have a B12 deficiency syndromes or receptor defects, and then follow up with a panel testing. We currently don't do much of it's very hard to order and expensive, and it's only done in Dr. Rosenblatt's lab in McGill in Montreal. The fibroblast and C14 incorporation assays to detect the activity MAT0 versus MAT-, or to do the complementation to identify which of the other subclasses, cobalamin A, B, or C. This is available. It's very helpful on a research basis for sure, and no mutations are identified in the genetic panel, but it's not done so much routinely. So we measure the maternal B12 and start B12 treatment immediately. Now, just 2 points to point out that lactic acidosis is seen in the SACLA defects, succinate ligase deficiency. And then the important to remember that in the combined malonic and methylmalonic acidemia, it will be missed in our newborn screening that is based on propionyl carnitine detection. In Quebec and Canada, they do newborn screening by urine, and then they will detect the malonic and methylmalonic acid in the urine. So it has a normal propionyl carnitine because the defect is a methylmalonyl CoA synthetase that produces methylmalonyl CoA from the MMA, and they cannot make that. So the C3 and C4 disease species won't accumulate in the plasma. So CMAMA will have a normal C3. Any questions so far for the original workup of a positive C3 screen?
There was a question from D. Burkhart asking about substitutions for cyanocobalamin versus hydroxo. Are there any major contraindications in these disorders for the substitution of cyano for anything? It's a common substitution for pharmacies.
So in all the defects, the most effective form is the hydroxycobalamin. Cyanocobalamin is definitely contraindicated in cobalamin C because the MMA-CHC protein is required to process the cyanide moiety of cyanocobalamin. Cobalamin A patients can be and have been in cyanocobalamin. The contraindication is for the cobalamin C specifically, but many times when they ask us, we say any cobalamin is better than no cobalamin. If it takes you a week to get the hydroxycobalamin, it's hard to get. Betaine will always take longer to start for a cobalamin C patient. So use cyano if you have to, but if you find out it is cobalamin C, like the homocysteine is very high, looks like a cobalamin C defect, it's urgent to change the cyano to hydroxycobalamin. Does that answer your question? Yeah.
Great, Pearl. That's
Thank you.
Thank you.
All right. So phenotype is very diverse. It affects multiple organ systems. And this is for the classic methylmalonic acidemia. Patients have, I start with the common ones. They have GI issues, feeding difficulties, failure to thrive. It has been very important that we are able to do gastrostomy tubes in the infants and young babies because the first couple of years that they have many viral infections and the compensations, the G-tube is important to provide fluids and calories and sick day diet and all that. So GI issues are very common. They can have recurrent pancreatitis. About 80% will develop chronic renal disease. Chronic renal disease starts in infancy or in early childhood. We don't detect it until later on, but we have to think of the kidneys from the beginning in the patients. And unfortunately, we don't do much in terms of renal protection in the children. So think of the kidneys. Every acute compensation will cause an acute on top of their chronic renal injury, and avoid renal toxic medications. Watch the hypertension, watch potassium supplementation. Be very careful of anything kidney related from diagnosis, because it starts very early on. I saw a hand being raised. Is there another question here?
Dr. Suchi was asking if there's any labs that still in Canada or the US are doing cobalamin complementation studies on a clinical basis. And she thought that maybe David Rosenblatt's lab wasn't doing them clinically anymore. I thought that they were.
I think they're still, I don't know if they officially request, but we have recently sent again to Dr. Rosenblatt. It's not a routine, it has to be sent, it usually is only for the cases that are a research question, like you have only one mutation and cannot detect the second one, or it looks like it is a cobalamin disorder and has been negative on panels. He still collects these interesting cases, has programs to run exomes, RNA-seq. He has done recently a lot of genomic screens on this, and this is how we identified these new disorders, the PRDX1 and the HCFC1 and those new defects that are being discovered. So he's on a research basis still active and interested and available, but I know that it's closing, it's getting accepting less samples. The other lab is of course in Switzerland, Dr. Baumgartner's lab. Patrick Forney and Matthias Baumgartner in Switzerland have the C14 protein incorporation assays and complementation. So those are the two labs, but from the US, we have been sending it to Dr. Rosenblatt. Okay, answer the question yet? So chronic renal disease, intellectual impairment. Intellectual impairment is common, but it's not universal. Like there are many cases with very severe MMA that have normal IQs in young adulthood. So it's not, it can be prevented. Of course, it depends on the hyperammonemia presentation and recurrent or chronic hyperammonemias very much, but it's not, there's a range. The basal ganglia strokes is maybe the most devastating complication in MMA. Thankfully, we see less of those early strokes in milder patients that were detected later in life and presented with a massive metabolic stroke. So cobalamin A, B defects that we had very catastrophic strokes, we see less of that because of newborn screening, but it's still likely and it can happen even after liver transplant in severe cases. So it remains a difficult to treat manifestation that we won't prevent with liver transplants or gene therapies easily. The brain will continue to suffer from MMA despite our new treatments. Optic nerve atrophy, again, is another very debilitating complication. Usually happens the second to third decade when the kidney disease is more advanced. Kids have thinning of the optic nerve layer and subacute or acute vision loss. I treat that as a medical emergency, quite like a metabolic hyperammonemia. So it can be subtle, it can be slow occurring, but we have to act urgently, bring the patient, admit, check labs, check IV fluids, everything that we do for a metabolic ketoacidosis. It may not be associated with metabolic ketoacidosis, but something is causing a severe vision change is urgent to manage. And we give antioxidants, we try to optimize the management, see if we can delay or reverse some of the vision. We have people that lost the vision completely, and it has been a very severe, of course, complication. The MMA, this is more prevalent in the chronic acidemia, of course, population, but MMAs can have long QTs or arrhythmias, especially during crisis. And we have a few patients that have severe hypertension. When they have renal disease, they can have hypertrophic cardiomyopathy or cardiomyopathy. So the heart is always something to keep an eye on. Hepatomegaly, fatty liver, non-alcoholic steatohepatitis, there are some cases that can progress to cirrhosis, and there are 3 reports of hepatocellular carcinoma. So there is something again to watch carefully. Osteopenia, bone marrow failure, pancytopenias, and immunodeficiency are again very common. And the manifestation that brings the patients most often to the clinics and the admitted and the ICUs is the propensity to have recurrent metabolic ketoacidosis with severe hyperammonemia, and that can lead to coma. Factors that affect the disease severity, the genotype and the enzymatic activity. MAT0 is worse than MAT-, cobalamin A and responsive defects are milder. We know of certain mutations, G7-1V, some African variants, Hispanic variants that are milder in the MAT. We have genotype phenotype for all of the disorders, that we know some variants that are milder than others. The time of diagnosis, if we pick them up at newborn screening and treat them early, we will have less complications. Of course, the severity of neonatal hyperammonemia is a major risk factor for later neurological complications, and the late presentation, as I say, cases that get undetected at newborn screening can present with a very severe metabolic stroke or a complication. And then B12 responsiveness is something we check right away at diagnosis. It can be done in vitro, of course, with a fibroblast assay. That's how Dr. Rosenblatt's lab will check to see if the patient is responsive. It's a MAT-. If it is not responsive, it's a MAT-0. And in vivo with injections of B12 for 5 days. And now we have a new isotope technique that we developed in our lab to look for enzymatic severity. So again, the B12 responsive subtypes are much milder. They have normal growth, higher protein tolerance, later onset renal disease, better normal cognition, and lower risk for, but remain at risk for CNS complications. And the unresponsive types will have severe numerous hospitalization, hyperammonemia, will have gastrostomy feeds. Many patients never learn to eat, they just are fed by the gastrostomy tube. Earlier onset kidney disease in the first decade. We have people with CKD3 at age 2, cognitive impairment, recurrent pancreatitis, bone marrow failure, optic nerve atrophy, osteopenia, higher morbidity and mortality. Mortality hasn't changed very much since the disease detection, and it is much more severe in the B12 non-responsive, the MAT-0 and cobalamin B. It's completely different for the cobalamin A subjects. Serum biomarkers, many times people say it should be measured serum MMA. Does it help us with anything? I think overall it helps to monitor the patients over time for the MMA to see when the kidney disease will come on. When the GFR is less than 50, the serum MMA will be over 1,000, and you cannot treat that with reducing the protein in the diet or any manifestation. This is just because of the filtration defect that the serum MMA will be very elevated. Children with MAT0 MMA will start with MMA. Serum MMA is in the 2 to 3, 400 range. And then as the kidneys become more affected, it will rise to 800, 1,000. We have patients at kidney disease stage 3 or 4 with MMA 14,000 micromole per liter, 14 millimolar. Very, very elevated. And when they are in those ranges here, we do worry for the optic nerve disease and acute optic nerve vision loss. Patients that are in these ranges, they will have optic nerve thinning. So we know they are at risk to have optic nerve damage. And we would try to push for earlier decisions about kidney transplant or liver and kidney transplants. So it is helpful for this kind of discussions with a nephrologist and the family. MAT minus patients will stay in the low 200 range. Cobalamin A are very, very low, like 50, 60 with a B12 shot. And cobalamin B is a range. The milder cobalamin Bs will be more in the MAT minus range, and the severe, just like MAT0 MMA. We have this new biomarker again that corresponds against with the disease severity, FGF21 and GDF15. Those are mitochondrial biomarkers. FGF21 is much more elevated in MMA. Both are elevated in MMA and propionic acidemia. So I put it here as another marker to use. And this is our propionic breath test. We try to develop something to assess disease severity that could help us guide the patients for a liver transplant early or not, or as if they're a good candidate for a gene therapy or mRNA therapy or one of those experimental therapies. And then track the response to the treatment, because we knew serum MMA is a very variable marker that depends on the protein intake every day and the kidney disease. So we have this C13 propionate breath test where we give them, it's like the fibroblast assay where we see if someone is MAT0 versus MAT minus. We give them radio label C13, C14 propionate in the fibroblast assay. We give them C13, that's a stable isotope, not radioactive. It's an oral bolus, very safe to use, and it's oxidized to C13 CO2. And we look the enrichment in the exhaled breath over time. We don't need 2 hours. We have been doing this for 2 hours, but in an hour, we see how much is oxidized. Very easy breath test, totally doable in 2-year-olds and easy to tolerate by the patients. And we collect breath by with a balloon here or through a nasal cannula on a machine, and we get the result in about an hour. So it correlates very well with disease severity, like with your cognitive outcomes. And the low ones, the patients that have low oxidation have much earlier onset kidney disease than the ones that have later oxidation. You see here less than 10% have a median reach chronic kidney disease stage 3 at age 8, as opposed to 34 when they have much milder enzymatic defects. So that's and then we can use that to track the increase in enzymatic activity. Now with a liver transplant here, not so much with the kidney. And then when we have mRNA or gene therapy, we will be able to track the improvement there.
Irene, real quick, there's a question in the chat from D. Burkhardt. Are there age limitations on that assay, specifically thinking about NICU kids?
So theoretically, stable isotopes have been used in newborns. It's very easy it needs training, and we have to have labs to measure them to make it more available to more centers. But we were hoping that centers that do the experimental treatments should be able to do. It's like a H. pylori urea breath test that gastroenterologists and ER departments use. Just drink urea and then blow in 3 tubes, send it to the lab, and you know if you have H. pylori in your and save yourself a gastroscopy. So it's easy to do it. It could be commercialized if we find it helpful to in a bigger scale. But right now we do metabolic cards and we do the isotopes. It's a more complex procedure that we want to use for our experimental trials. But there is no age limitation. Yes, the stable isotope is safe and can be used in babies. It needs some coordination, but between the nasal cannula and the breathing, we have done it in autistic kids, very developmentally delayed patients. It has been easy to do in our hands. Okay, yes, moving on, treatment approaches. So for the treatment, we try to lower the influx to the propionyl-CoA pathway here. So we try to reduce the protein intake. We use propionate, the specific amino acid deficient formulas and antibiotics to lower propionate that comes from the gut flora and from the protein in the diet. We use carnitine. Carnitine binds to the propionyl-CoA, making the propionate carnitine. It's more water soluble and can be excreted in the kidney. So we use carnitine. We use high dose carnitine IV during crisis to help detoxify some of the extra CoA species. Anaplerosis, there is a lot of discussion about anaplerotic agents. We recommend liberal use of citrate if the kids have chronic acidosis. Many have low level chronic acidosis. They have CO2s that are in the 19 to 20 range or 18, and we like to keep them at 24. So we treat the chronic acidosis more proactively, and citrate serves also as an anaplerotic agent in the Krebs cycle. And then antioxidants, we don't recommend universal use of antioxidants for life, but during periods or when the children have lactic acidosis or are more prone to the compensations, if they have thinning of the optic nerve, it's something to add to their management. Again, there is no randomized controlled trials. It's like the same situation with mitochondrial disease. We have limited therapies, but a good mito-targeted antioxidant would have a place in MMA. Now, carglumic acid, I have another slide on the Carbiglu was approved this year in January for MMA and PA acute hyperammonemia. And of course, the more effective therapies are B12 if the patient has a B12 responsive defect, liver transplant, and gene or cell therapies. Highly recommend to go over the guidelines. There is two. There was the first was published in 2014. This is the group in Europe, Dr. Baumgartner, very experienced, and also Kim Chapman from Children's, and other people here have put together these guidelines for the diagnosis and management of MMA and PA. And this year there was a update, the first revision in the guidelines. The main changes were a more thorough discussion of the transplantation outcomes and recommendations, and then the dietary changes. They have very detailed tables with detailed instructions about management of hyperammonemia, the levels of ammonia and how to start ammonia scavenging medications, the doses for carnitine, sodium benzoate, avoid sodium methylphenylbutyrate because it can deplete the glutamine that is and sometimes slow in MMA and PA hyperammonemia, and Carbiglu. And then they recommend the glucose infusion rates for each age group. We try to avoid very high glucose infusion rates. You need insulin to keep the kids anabolic when you cannot use the gut or have pancreatitis and you cannot use a lot of fat. So GIR, and it's a balance between giving them enough calories with insulin and glucose and avoiding severe lactic acidosis. When they have lactic acidosis, we add thiamine because it's a PDH reaction that we need to support during the crisis. And then they have also calories and protein requirements for each age group. Overall, I have a 1 kilogram per day of natural protein as a recommended daily intake, and I will talk about the diets in a little bit more. So
one quick question that came up in the chat from Dr. Prasad. Is there a chronic role for Carbiglu use in MMA and PA prevention? I'm assuming of decompensations or chronic prevention.
The approval is for the hyperammonemia. And there are ongoing studies that have used it for chronic and prevention. The data are not as strong, and not well, they're not placebo-controlled trials, the ones that I'm aware of. So it is an ongoing process to see if they can prevent recurrent hospitalizations. It's currently not recommended. We have had patients come in that used Carbiglu like in anticipation of a crisis, like if you travel and you won't be, like we had physicians prescribe it for a short time when they're very worried because the family has some, so not just during severe hyperammonemia, but kind of as, but to stay on for life on Carbiglu, it's very expensive at this point, and it hasn't been shown to be effective in a convincing randomized control trial to get approval for that. So for right now, the approval is for acute crisis. Okay. So why is it difficult to treat these diseases? They're very, we say we do all those supportive measures and the kids continue to develop complications and will have decompensations and all of that. They're really very hard to treat. And there was a paper here just reflecting what we all know, that some of our amino acid disorders are very responsive to diet, and our medical foods and diets were critical in the improvement of the neurocognitive outcome. That's not the case for these later defects. They have limited efficacy, and there is a lot of endogenous production of the metabolites. And I have here the branching amino acid pathway just to show that those early steps and the amino acid disorders, MSUD, is treated quite effectively with diet. That's not the case for these lower defects that are very close to the mitochondria, close to the Krebs cycle, and have this multi-organ secondary mitochondrial dysfunction. And I'll show you additional disease mechanisms that are hard to target. So this is the reversible transamination step, the irreversible decarboxylation step, and then organic acidemias. They excrete the carbon-based acids, and it causes energy deficiency, secondary mitochondrial defect that is harder to treat. They have this cell autonomous mitochondrial dysfunction. We have a lot of experience with our mouse models and patient tissues, and have our mouse models replicate the patients really well. Those are liver samples and proximal tubules. So cell autonomous, we mean that one specific cell type is very abnormal in MMA. The neighboring cell, like the distal tubules in the kidney, are fine. The proximal tubules that are very energy dependent, their mitochondria look completely, this is a normal mitochondria that's dense, it has all the cristae and normal shape. We have an expansion, and we have numerous mitochondria take over all the cell, and they're very pale without cristae, very abnormal looking, both in patients' liver, kidneys, and mice. And then we have secondary cytochrome C oxidase deficiency, again in liver and kidneys, and in the retina. This is from an autopsy in a patient. Again, those are mitochondria here in the photoreceptors in the retina that show very abnormal mitochondria. So it is a mitochondrial disease in the cell-specific distribution. Now, this is a very recent paper that goes even deeper in the mechanism of mitochondrial dysfunction and describes a defect in mitophagy. That's a normal process where the abnormal mitochondria are absorbed in the cell and removed. So there is a ping, they cannot prime and target this abnormal mitochondria to the autophagy lysosome complex to destroy. So they accumulate, the abnormal mitochondria have this proliferation, and then oxidative stress and mitochondrial dysfunction. Very nice paper, and a couple of reviews following that paper. And the talk is in the seminar series that the link is provided in the chat. And then we have CoA accretion. So remember, we have propionyl carnitine, methylmalonyl carnitine. These CoA species accrete in the mitochondria. This was an earlier paper calling them castor disorders, CoA sequestration toxicity phenomenon. It's very nice mechanistic paper about how this can cause secondary dysfunction. In our lab recently, I just borrowed that from our postdoc, Pamela Aresara Head, who works on this post-translational modification, how the propionyl methylmalonyl species acetylate in the neutral pH of the mitochondria. You don't even need the enzymatic reactions to do that. The acyl species do acylate the lysine residues and proteins, and inactivate enzymes. And she's doing some work on the CPS1 and the protein H of the glycine cleavage system to explain why we have the hyperammonemia and the hyperglycemia in MMA and PA. So to be continued here. So recent changes in the management of MMA. As I said, carglumic acid has been approved for acute hyperammonemia this year. We refer patients earlier for liver transplantation. I think that has been a major shift. We see patients be referred in the first year of life. Sometimes we worry if this is too early and if we know for certain that the patient is a MAT0, clearly MAT0 patient, if they don't have two nonsense mutations, they don't have the time to have established themselves as a very severe fragile case, but early referral will prevent this recurrent hospitalization the first couple of years of life, and it has been attempted recently. We have to see how these patients fare in the coming years. Then we have this changing guidelines about the use of medical foods, and I will go a little bit into that, and the gastrostomy tube placement that is more common ground now. And antioxidants and periodic agents are all kind of attempted. And then higher doses of concentrated B12 for the cobalamin C. So carglumic acid, I urge you to read the mechanism and the papers for that, but in MMA and PA, you have propionyl-CoA that inhibits the Nagas reaction and reduced acetyl-CoA to synthesize an acetylglutamate that stimulates the CPS1 reaction. So N-carbamyl glutamate is an activator for the CPS1 to help the urea cycle and lower the ammonia. And it was shown to increase urea synthesis and to lower the ammonia really rapidly in the neonates. And it's now approved for acute management. Okay, so liver transplantation. So in this lifespan of MMA, traditionally, we were waiting for the kidney disease to become more advanced to recommend either a liver and kidney transplant where the children were very severely affected and had renal dysfunction, or an isolated kidney transplant if they are MAT minus or milder affected and the primary failing organ is the kidney. So now this is more, the trend is to use more liver transplant only in the earlier ages, as early as first year of life or second year of life. So liver only for the severe MAT0 and cobalamin patient that have frequent hospitalization, severe crisis, hyperammonemia, minimal protein tolerance, poor growth. Liver kidney, if the patients go over that early few years and start having kidney disease, then they can have a double transplant that will protect them longer term. And the liver transplant protects the kidney also, and they can have better survival of the transplanted organs over time. And then if the patient is older and doesn't have this fragility and the recurrent compensation, and they have renal failure, they can have a kidney-only transplant. Large liver transplant will eliminate the metabolic crisis. It has this morbidity, mortality in experienced centers is much better these years, recent years. It improves the appetite, the growth, and slows the organ complications. But we have a lot of, sometimes there is surgical complications, thrombotic events, rejections. They need chronic immunosuppression. We had a couple kids develop post-transplant lymphoproliferative disease. That's quite a severe complication. And it lowers, but it doesn't completely normalize the metabolite. And it doesn't prevent completely the central nervous system complications. So MMA will be significantly improved. And that happens more when you replace the kidney as well as the liver, because again, the kidney is what causes this very high MMA values, the kidney failure. It will improve the glycine, the MMA, and the ammonia from MMA and PA, but of course, they're not normal. And as I say, the children can still develop the basal ganglia strokes of MMA. Just show you here two MAT0 patients and cobalamin B patients that have this globus pallidi infarcts in the basal ganglia. They get this movement disorder, they can be wheelchair bound, it's severe choroathetosis, but cognitively can be normal. So it's a very disabling complication. Couple of words on medical nutrition therapy. we have to use a combination of natural protein and deficient protein to support calorically the children and manage MMA, PA. The MMA, PA formula, like all the metabolic and medical foods, they lack essential amino acids. So they don't have valine, isoleucine, methionine, and threonine. No one can live on these foods. You will become catabolic. You need every essential amino acid to stay in balance. So you have to have a recommended daily amount for the natural protein, and then the correct amount of medical foods to be in good control. We had, for many years, there were children that were taking valine isoleucine supplements, and that was very counterintuitive for us because valine isoleucine turned to MMA. So there should be no need for valine isoleucine supplements in MMA. They're not like MSUD. In MSUD, we need to supplement with valine isoleucine, not in MMA. It was kind of the imbalance of the prescription of nutrition that caused these amino acid deficiencies. So with proper tuning of the diet, they should be able to come off the valine isoleucine supplements. And I could just compare to children as a kind of clinical case to show you that kids can be managed without medical foods. And we had these extremes where you have a very severe patient that has no medical food and a similarly severe patient that is on a very large amount of medical foods. That helped us realize what the issues were with diets. So those both children have growth delay. She's very obese, very small head circumference. A lot of their body composition is fat. Remember that for the dietary prescriptions, we do want to feed the lean mass, the muscle and the bones, not so much the fat. So sometimes the per kilo calculations are wrong, and we have to use an ideal weight or adjust the weight to use the lean mass body weight for protein tolerance determinations. So about 1 gram per kilogram per day is the recommended daily amount. This young girl was taking all the nutrition from natural protein. And this severe patient was on a very low amount of intact protein and like almost double the amount on medical foods. That was a pattern that was wrong. And she had always valine isoleucine deficiency. And this is what valine isoleucine deficiency will look like. You have peeling of the skin and hair loss. So those are signs of essential amino acid deficiencies. This was because, when we removed all these 4 amino acids from the medical foods in MMA, we left leucine, which is one of the 3 branch chains, right? Leucine was left in the food because it doesn't feed to the MMA pathway. And for some reason, it was doubled in the medical foods because you have to make up for 4 amino acids that were removed. So leucine is a good amino acid, has anabolic properties, so they made up with more leucine. But when you prescribe a lot more, a big amount of medical foods, you end up having a very significant leucine intake, 4 to 5 times the recommended amount. And that will lower the valine isoleucine for the 3-4 hours right after ingestion. So it acts like a load of leucine to the body. And there have been multiple studies showing that when you give someone a leucine load, you will start oxidizing your valine isoleucine because your body takes the signal that there's a lot of branching amino acids on board, so I can start burning them down. I have that here, that when you give leucine, you will make ketoisocaproic. That is an inhibitor of the kinase. It stimulates the dehydrogenase reaction, the MSUD step, right? And it will increase the branching amino acid oxidation. So we were doing that with our prescribing the medical foods. That's why we use very low amino acids right after they have the medical foods. And people were tracing those low values to make sure they don't lack essential amino acids. But that was a temporary effect from the leucine load, and it can be easily managed by managing when to draw the labs and how to interpret the findings. The other effect of leucine is that it competes for the uptake to the brain for the other large neutral amino acids. So it will cause lower valine isoleucine methionine levels in the CSF if it is in excess. That could be detrimental when your brain is growing or you have cobalamin C and you have very low methionine, but it could be a good thing if you need to lower the MMA production in the brain or the other organ systems. So that's the fine tuning is difficult. And I have here kind of a very graphic presentation that it is a balancing act between giving too much medical foods over the natural protein, too little, and getting it just about right. So if you give too much, this is like about 1 gram per kilogram per day, the recommended daily amount, another gram of medical foods. This is what we were traditionally doing, 50-50, twice the recommended amount, half of it natural protein, half of it medical food, or even more medical foods than natural protein. This is definitely wrong, and we should not do this anymore. And this high protein prescription causes overfeeding, a lot of nitrogen for a case with at risk for hyperammonemia and kidney disease. And this high leucine will cause this lowering of valine and isoleucine, poor growth, microcephaly, affect brain growth, affect bone density, and other organ growth. On the other hand, if we use too little protein or not at all medical foods or very little, we could have short stature, low essential amino acid, again, bone marrow suppression, and delayed puberty. So for this scenario, we want to make sure we check the time of the blood draw. It has to happen away from 4 hours from the ingestion of medical foods, if you can time it. If not, pay attention to when it's drawn and what the kid had this morning. And you need to decrease the medical foods, not increase the intact protein, because it may be a very severe case that cannot tolerate more intact protein, and don't supplement with valine isoleucine. And in this case, we never advocate against all medical food because there is a benefit. Leucine has anabolic effects and could delay complications from the different organs once the growth is complete. So we hesitate completely discontinuing the medical foods, even in children after transplant, because there could be some benefit of keeping them on a right amount for even after transplant. So this changed these propionic guidelines that were adjusted from recommended 200% daily amount of total protein to about 120 to 150, and 2/3 to 1/3 ratio of complete protein to deficient protein is about the right amount. And for long-term monitoring, you review the emergency plan, you have an emergency letter in place, the med alert bracelet, especially in older children or as a transition away from home, is very important. Regular eye exams, hearing evaluations, echocardiogram, abdominal ultrasound, manage osteopenia. This is relevant because for the renal disease, we need to refer them early to nephrology and treat proactively with calcitriol and try to keep the bones healthy and deal with the kidneys early on, and all this other long-term monitoring. 2 words on experimental therapies. I'll go really a bit fast here. So those trials are open and enrolling, and they have already dosed patients. There's a small molecule trial. Kim Chapman at Children's National is leading the trial with an oral daily medication, genome editing for mild MMA. Again, 1 patient has been dosed, and systemic mRNA therapy. Again, 1 patient was dosed in Birmingham in the UK. So those are all open and enrolling. You will hear a lot more in the coming years. That's a very exciting time for young trainees in metabolism. There's a lot in the works, and finally we have new things that hopefully will change the natural history for these very severe diseases. So that's the oral therapy. It decreases MMA and PA-CoA pool in the organs. It does penetrate in the CNS, so it has a potential to act in the neurological complications, and it's a once daily oral dosing. The mechanism of action are unclear, but it has been developed in human primary hepatocytes, and it has been used in other diseases, and it's considered overall safe. The trial is open. And the mRNA therapy, they have an mRNA. Moderna is delivering mRNA for the MAT or the PCCA enzyme, PCA-NB for the propionic acidemia. This will need to be at least a monthly infusion, if not more frequent. It's IV treatment, and but the RNA does go in the mitochondria, expresses the enzyme, and is effective. We did the preliminary studies in our lab, and we'll see how it works in real life. The genome editing is a AV-mediated, promoterless, nuclease-free genome editing. It goes in the liver, in the albumin locus, it integrates, and it produces a modified, uses the albumin promoter to make a lot of MAT enzyme. It's a very low efficiency system because there's not enough integrations at the beginning. So you have to use a higher dose as a starting dose for that and use younger children, because the growth of the hepatocytes with time will lead to this, hopefully, advantage of transduced hepatocytes that have a survival advantage over the sick hepatocytes. At least we see that in the mouse models. We don't know if this will happen in children, or how old the children need to be and how long we need to wait to see this advantage. But theoretically, this is permanent, it's integrating, and it will lead to improved enzyme production over time. And then the more traditional gene therapy is coming up. I'll go a little fast so we have some time to discuss cobalamin disorders. So, and the talks in the seminar, there's a lot of talk of Dr. Venditti on all those experimental and gene therapies, and we will hear at conferences and at the meetings coming up how this will go in this patient population. So cobalamin C, now changing gears. Cobalamin C is it's a common defect. It's very common in China. It's like 1 in 2,000 to 4,000 in certain areas in China. It's pan-ethnic in all populations. It causes, again, a multi-organ disease, primarily neurological manifestations and vision loss, eye findings. The children develop very early, severe bullseye maculopathy. So they have a retinal degeneration in the macula that affects the central vision, starting in the first few months of life and leading to vision loss in early childhood. And they have microcephaly, hydrocephalus, seizures, intellectual impairment, psychiatric disorders, peripheral neuropathy, fatty liver, hepatomegaly. If they're not picked up on newborn screening and they present a bit later in childhood, they can have hemolytic uremic syndrome, thrombotic macroangiopathy, thromboembolic episodes because of the very high homocysteine, failure to thrive, osteopenia, megaloblastic anemia, and they can have non-compaction cardiomyopathy. It's a common finding in the severe early onset cobalamin Cs. Manifestations can start in utero. That's a very important part of this disease. So babies can be born small UGR or small 4H with microcephaly, can have macular choroboma, congenital heart defects, or fetal hydrops. So treatment ideally can start in utero if possible. Those patients need daily hydroxycobalamin shots and betaine to help with them. Betaine methyltransferase make more methionine from homocysteine. So we boost those two reactions. They need to be on both those medications. Folinic acid and carnitine, it varies between clinics. Others use folate, others folinic. Carnitine is used, but usually with enough B12, the MMA, serum MMA is very, very low, and we haven't had people with low carnitines, but it's good to keep an eye and supplement if needed. So, and this is the one that cyanocobalamin is contraindicated. That definitely will make the patient worse, cannot be processed. For a couple of days, as I said in the very beginning, you have to use cobalamin until you get the hydroxycobalamin, but for long-term use, it's very important to get the hydroxyl form. It presents throughout the age ranges, can start prenatally or in the newborns, in infancy, in children, or even in adults. So you have psychiatric presentations, as I said, the renal presentation, pulmonary hypertension, encephalopathy, extrapyramidal signs, subacute cord degeneration, neuropathy, psychosis, and those neurological presentations in the late onset cases will not respond to therapy, unfortunately. So we have an improvement in the metabolites, improvement of the thrombotic complications, but the neurological presentation and the spinal cord syndrome is resistant to even higher dose B12. So maculopathy, this is a normal retina, the optic nerve, the macular area. They get this bullseye maculopathy in the area for the central vision. And then with the progression of the disease, they get a salt pepper type retinopathy, pigmentary retinopathy, and then optic nerve atrophy. As I said, it starts early, 4 months, 7 months. and then this very advanced disease as the patient's age. And 2200 is the line for the legal blindness. And you see here that very young children can be completely, very severely visually impaired. And by the first decade, a good number reach that visual blindness, legal blindness threshold. So what happened with over time, that 1 milligram every day dose was not effective as the children outgrew that dose when they age. So Dr. Van Hove in Colorado and had used 5 milligram a day in a hemolytic uremic syndrome case. And we did then a dose escalation study. We brought the patient carefully back at an age to show that with increasing the B12 from 1 milligram 3 times a week to 10 milligrams a day or 20 milligrams a day, you will see a good response in the biochemistry for total homocysteine and serum MMA and an increase in methionine. And then we did in many more patients, increase the dose of the B12 up to 20 milligrams every day in the adults, now in the kind of teenagers to adult, and seeing this good biochemical response. The problem is you would not reverse the neurological manifestations of the eye findings if you do this later. You will prevent long-term thrombotic complication, cardiovascular health. It's much better to have a homocysteine in the 20s to 30s rather than 150 or so. So it's better biochemical control is overall good for long-term complications, but the established manifestations would not improve. And it's expensive, it's hard to get, needs compounding, it's not FDA approved. And we have tried for the last couple of years to make some progress and have it become formulary so that more people can prescribe. And it remains to be seen if we can improve the phenotypes when we use it very early. I have this here to make again the point of starting early. So in the cobalamin C children, treating in pregnancy was shown in this case to be very efficacious. The sister that was a symptomatic presentation, that's a European case report, presented that it was diagnosed early, but was treated with the traditional 1 milligram per day or less frequent originally, severe delay, severe vision loss, unable to walk, nonverbal. The second sister was diagnosed in utero, prenatal testing, amniocentesis, got B12 10 milligrams 3 times a week, and then 1 milligram a day, and increased the dose to 10 milligram twice a week postnatally, and had a good IQ, normal vision. Again, this is a milder second variant. It's not the homozygous 271 Dupai patient, but that shows that very early treatment is critical. So for cobalamin C babies, every day counts in the beginning in the diagnosis, which really have to be aggressive with B12 management. And it remains to be seen, and we hope to have a trial to study more careful, the proper trial to show that starting higher doses, 5 milligram every day or even higher, as was done in Belgium in a recent case report, could change the eye phenotype. We have seen patients that escalate the dose in childhood, and we have started seeing patients with better neurocognitive outcomes. But a trial needs to be done to, prove efficacy and safety and get FDA approval. But for the cobalamin Cs, emphasis here is on the methionine. We use hydroxycobalamin and betaine, but we don't worry as much about the MMA part of the pathway. We worry about the low methionine synthesis. So we cannot severely protein restrict these children, and we should not use the formulas that have no methionine. There is 2 reasons why the MMA formulas are contraindicated in cobalamin C. They don't have methionine. Valine-solution methionine and threonine are the amino acids that make MMA, but also they have the high leucine that we discussed. It competes through the large number of amino acids for the uptake of methionine. So they have 2 reasons that the brain methionine will be extremely low in these children. So no formulas for cobalamin C, and protein restriction not in the younger children. We want them to have a lot of methionine to help with the brain growth early on. when they are older, because even 20 milligrams a day in the older kids may not completely control the metabolites. We usually recommend the families to stay on a vegetarian RDA, close to RDA diet, because if they are on 2 or 3 times RDA, we cannot control the homocysteine when they are older. So again, just saying this, you can read in the papers showing that more formulas in 2 studies, that's at CHOP, and that's our study showing more formulas in these patients had microcephaly in 2 reports. Our lab again tries to develop gene therapy for cobalamin C. It works really well in the mice. We have mice that die the first week of life, and with gene therapy and prenatal and postnatal hydroxycobalamin, they have much better survival. We're really hoping to get the gene therapy for cobalamin C for the maculopathy to deliver locally subretinal injections like an already approved Luxturna for Leber's congenital amaurosis. But our mouse models, both our mouse and a recently published mouse that's floxed, and we're trying to get MMACHC deficiency in the retina specifically. Both of them don't replicate the maculopathy of cobalamin C to prove efficacy for the eye findings. So research is ongoing on that. And I will really kind of quickly mention the other early defects for completion, but again, this is too many defects, and I don't know if people follow still. It's a lot of different diseases, but just a few highlights for each of them. So there is a transcobalamin deficiency. This is a severe defect, and it can resemble neonatal leukemia or SCID. They have macrocytic anemia and pancytopenia early on, but they're very responsive to hydroxycobalamin in injections. The TCBLR defect is a much milder again phenotype. It's very common. The first cases were identified with increased C3. They resolve even without treatment. But the natural history is unknown. We recommend hydroxycobalamin at least originally, and then maybe oral later. But we don't know if they have a phenotype, if the B12 is low or under some stress. So it's we have to follow up with this defect. Cobalamin F and J deficiencies, those are the lysosomal that transport the cobalamin out of the lysosome in the cytoplasm. They're very interesting, very rare diseases. The interesting part here that is unusual for our intracellular B12 metabolic disorders is that they can have low serum B12 levels and abnormal shielding tests, which is unclear why, but this is an interesting point. And they both can have congenital heart defects, in addition to stomatitis, glossitis, seizures, hypotonia, failure to thrive, and other findings. So they have combined MMA and total homocystinuria. The cobalamin D is a very interesting enzyme that causes kind of 3 different diseases. So it can cause isolated methylmalonic aciduria, isolated homocystinuria, or combined, depending on where the mutations are. 5' mutations are more MMA causing, 3' homocystinuria. And then, so early loss of the whole protein will have MMA or combined defect. Later mutations, they escape and they have another starting codon, and you can have just homocystinuria. So it's an interesting gene, and again, very rare. Developmental delay, seizures, ataxia, psychosis. They can have the eye findings, and then they are responsive to hydroxycobalamin. And then cobalamin E and cobalamin G deficiencies, they have early onset and late presentations, and then there is an Iberian mutation in the reductase, the cobalamin E phenotype that is more milder and causes isolated megaloblastic anemia. They have isolated hyperhomocystinemia and low methionine. They are missed at newborn screening. There is efforts now to improve our newborn screening with maybe adding total homocysteine even as a primary. So there is molecular testing. So we miss those babies with our current methods. So we have used only hydroxo or hydroxo and methylcobalamin, betaine, folate, and B6 to help the cystathionine beta synthase reaction as well for the homocystinuria. And then those are fascinating disorders, the regulatory defects. Again, the only X-linked inborn error in the intracellular B12 metabolic pathway is the HCFC1, the cobalamin X, we say X for X-linked here, and the epi-CBLC. Those were patients that had only one, had classic cobalamin C deficiency, very severe neurological phenotype, intractable seizures, severe presentation, and had high high homocysteine and MMA, but no mutation in the MMA-CHC gene. And it was with exome sequencing and studies. They have X-linked variants in the HCFC1 in the Kelch domain of this transcriptional co-regulator. It's a nuclear gene that regulates the expression of MMA-CHC. They respond to B12. And they found on exome, and they're hard to interpret because they're X-linked. Many labs interpret them as VUS. The molecular genetics here needs work. Now THAP11 and CNF143, each was one patient described for each. They interact with the HCFC1. And again, they resemble the cobalamin C. They are autosomal recessive. And then the epi-CBLC is the most recent MMA-CHC deficiency. Those were patients that had one mutation in MMA-CHC, classic, very classic, similar to the early onset cobalamin C with maculopathy, the same manifestations, but only with one mutation. The second mutation was in the last exon of another gene that's called PRDX1, that is a splice site mutation, skips the last exon and causes a read through with a long read through that is very close to the MMA-CHC. The promoter leads to hypermethylation of that promoter and then silencing of the MMA-CHC. Very fascinating defect and genetic find. So now PRDX1 has to be sequenced specifically to rule that epi-CBLC deficiency. Again, there are guidelines published by European colleagues, Martina Humer and the EHOT Consortium for all of the disorders. And just have that from our gene reviews. Jennifer Sloan has another very thorough gene review on all those defects where, the combined defect, if you have elevations of both MMA and homocysteine, you sequence the MMA-CHC. If two variants are found, you have CSC. If one variant is found, we have cases with a full MMA-CHC deletion. So you need to do array or more SNP or other analysis and PRDX1 sequencing if you find only one variant. If it's negative, you need to follow up with exome and or genome now because of those splice variants and interesting regulation of that gene with neighboring mutations. And then if MMA is normal and you have high homocysteine only, you go down the cobalamin D, E, and G. And of course, all our disorders that we discussed today have low methionine. That's very different to the high methionine for classic homocystinuria or MTHFR deficiency. And despite all of that, many defects, there is still a good number of cases with MMA, isolated or combined defects that remain undefined. And Dr. Rosenblatt, as I mentioned, has ongoing efforts. Those are two papers that did genome RNA sequencing in MMA cases of unknown cause. There are still more defects to be discovered. So for that, we need genome sequencing, cellular studies, animal modeling to identify the cause for these patients. And from the beginning, I mentioned that scientific webinar we had in June 24th and 25th this year. We had a full two-day webinar on updates on MMA, homocystinuria, and cobalamin disorders. And all the recordings are free, available on our website. We gave the link to the chat. And if you have time, and there is very nice, thorough talks on everything I mentioned today, the post-translational modifications and the mitophagy, Dr. Rosenblatt has an overview of all the cobalamin inborn errors, and Dr. Levy on homocystinuria, the EHOD colleagues from Europe. So highly recommend for the more in-depth discussions. So, and Dr. Venditti will be talking next week, right, Peter? For, I think, propionic, isovaleric, and I don't know if he does glutaric or other aciduria.
Yeah, he'll be covering most of the other organic acidemias. Yes,
Yes.
thank you, Dr. Manoli. That was excellent. Thank you very much for that comprehensive talk on MMA and cobalamin metabolism. Any questions? So nothing else came to the chat besides thanks to you for some folks who had to leave early for, I'm guessing, clinical duties, because we all have them. Any other questions for Dr. Manoli, though? I'm curious, while people are still thinking about things, do you follow many people prospectively after transplant? And specifically for MUT0 patients who are transplanted younger, have you guys run into any complications that were unexpected in those patients?
Yeah, thank you for that question. We have a very big cohort. We have watched 18 subjects for over a decade, some of them like three subjects we have known for since 2004 or 5, since the protocol started, and they were the oldest patient transplanted, and we were watching them every year, a couple of years for many years. Two of them passed away actually last year at age 37 and 38 or so, like late 30s. Yeah. And they had both LKTs. So we have experience with long-term follow-up. We don't have that many that were transplanted at 1 year of age or 2 years of age. This is a very young cohort. We know of Pittsburgh has a experience, and we have seen a couple of patients, but this is a recent trend. So we don't have 10-year follow-up of someone who was, the youngest we have follow-up was transplanted at 3 years. We have 2 or 3 that were transplanted at age 3. Or they are like 2 years, 8 months, or 3, and they are almost 18 years later, and they needed a kidney transplant at that point. So one of them needed a kidney, the other one is gonna need one, but not quite yet. And they have been very stable and doing really well. One has autism, but that was kind of, developed after his transplant, but the other one was cognitively quite well and quite stable. So those were the best kind of outcomes. Now we have others, of course, that had PTLD, as I mentioned, post-transplant for proliferative disease, like all kind of surgical complications, like thrombotic event, like perisurgical, and then other complications. But it's a mixed bag, unfortunately. I cannot. We have people that lost their vision or had metabolic stroke. Very clear that the most unexplained metabolic stroke happened in a perfectly well transplanted case, excellent management, normal procedure, no metabolic acidosis, not even an infection, kind of out of the blue, who went up, had 1 episode of vomiting with not very mild fever, and basal ganglia completely, like infarcts in both basal ganglia. It is a mystery, and we have really struggled to understand what were the combining factors. We have diabetes happen in a couple of people post-transplant, and in that case, there was some maybe calorie deficiency around that time. But again, we have no clear explanation. But yes, there are complications after transplant. It's not a, but the centers have become better. I see Arik has her hand up. So Arik, please go ahead. Maybe you have experience to share.
Irene, so yes, I have some experience with that, but actually I did want to ask a question. So thank you first for a really wonderful lecture, and everyone is really happy about it. So thanks. I do have a question. So the question that comes up from parents right now is, with children who are young and have MMA or PA, that question is coming for both, is with the advent of gene therapies being developed and then the presence of liver transplant as an option, what should they do? Because if they go into the liver transplant list, or they go on that end, they're not going to get gene therapy if that's going to be provided for at some point in time. So the question comes up for these parents are asking, what should they do now? You know, if they have a young child and they're waiting, you know, like they're under control, they're doing the dietary recommendations. How do you feel that this is something? And I've been saying I recommend that you go and talk with the group at NIH, but I just want to know.
A lot, and thank you all. We get a lot of these questions like constantly. And so far we have not been conflicted. So we are actually really in a good position to say, yes, wait for that, you're good for that, go for that transplant or the other transplant. We are trying to be very kind of as objective as one can be. We have always told parents, you cannot wait for the experimental therapies. We don't know when they will happen. They will only enroll a very small number of people. Like we're talking for a handful for each of the treatments in the beginning. We have to wait for the phase 1 and 2. So if we think someone has 2 stop mutations, a fragile case, we clearly say you could be transplanted tomorrow. It is an indication, you can do it. Go see the transplant surgeons, discuss with your physicians. This is you need the available treatment today is liver transplant. You can go for it. We don't know about the experimental therapies. We have not. Many families are still doing okay, and they're like waiting and see what else comes on the table. Now we have more options suddenly. Now we have suddenly from no options to having 2 or 3 studies enrolling, and a small molecule, an mRNA, and a gene therapy, genome editing therapy, right? So now there is more options and people, but it is again certain centers that can enroll with families. Transplant centers can offer both. So I think that the ideal approach, if I had a MAT0 case with 2 nonsense mutation, I think is to be considered for the gene therapy, because the transplant is always a fallback. Like you can always go for the liver transplant if you see an improvement for 2 or 3 years, or something doesn't work, or you have an immune response and you lose expression from the gene therapy. You can always have the liver transplant. Leave the gene therapy arm and go have your liver transplant. So ideally, centers that offer both therapies can discuss the options, discuss the pros and cons and eligibility criteria. And if you have antibodies, for example, for the AAV, you go for your transplant. So you can be evaluated and see if you are a good candidate for the available treatments, and consider contributing to the knowledge and to find out how they behave, or go for the liver transplant. So there are cases that are, of course, less. My worry for the early liver transplant is that we may transplant patients that may not absolutely need it. There is no clear cut, it's not that we have a certain severity threshold that you need to pass to necessarily decide for the liver transplant. So if we have 2 stop mutations in the MAT, and we know for cases of MAT0 clear, MAT0 case, then there's no problem. But sometimes we hear of patients with combined heterozygous that we know the second variant is milder or so. So we are we're not clear. We cannot say 100% that is the best option right now and so young, because if you're 1 year old, you have to think for 20, 30 years, 40 years ahead, not the immediate future. But having them stable the first 2 or 3 years could maybe improve the neurocognitive development and the growth, and the morbidity that is the biggest burden for the family. So yeah.
So I guess one of the questions are, would gene therapy provide enough enzyme activity for MUT0 patients or null mutations that it would be significant enough to prevent, delay the renal and other complications? Would that be something that is doable versus transplant, giving a liver that has more residual enzyme activity in general?
Gene therapy will never replace every cell in the liver like a liver transplant, right? So the liver transplant replaces all your cells in the full liver that have all normal MAT expression. That no gene therapy will achieve that. So there's going to be a percentage of the liver that is transduced, and it's a much easier. It's an IV infusion. We are trying to develop options that you can be reinfused. So there is ways to go for that, to see what will happen long term. But yes, it will be, not replacing 100% enzyme activity in all liver cells. So, but it's a trade-off for the big surgical procedure, the long-term immunosuppression, and all the other risks from the liver transplant. So we will, in a good scenario, the hope is that you will make a MAT0 patient to a MAT- patient, but there will never be always at best a milder enzyme defect, not, and we don't know what the threshold is. In the mouse models, 8% or 12% is enough to have complete rescue and on high protein diet. And so this is all the open questions to answer. But the easy thing to admit is that it will never be 100%. Yeah.
A great point. Also, and to follow up with that, tying into what I had asked, have you noticed excess complications in infants or younger kids that have been transplanted perioperatively? Just anecdotally, we have at least one who had a really rough post-transplant course, and our transplant team was blaming it largely on the metabolic disease, which we weren't sure. I mean, the literature doesn't support that, at least at this point. But observationally, have you seen that at all?
I have not seen more complicated, like, again, I don't have good numbers in those very young ones. The ones that I can recall now have done really relatively quite well. And in general, for us, the more disease burden you have, the worse the surgical complications are. I think the ones that have LKTs very late, like they're 20 or 18, sometimes the families were dragging and not taking the big decision until much later on. And then at that time, the optic nerve thinning is there, there is advanced renal disease and the additional comorbidities of the advanced renal disease, right? Severe osteopenia, hearing loss. So we have people that had a very successful surgery, a very successful transplant, but are blind, deaf, have severe comorbidities because they were in the second, third, kind of close to the third decade, and MMA has been, causing a lot of disease by that time. So then those surgeries are much more complicated because those are really fragile cases, have obesity, have very difficult management. I think the most complications, again, I'm not a transplant center. This is from our coming and discussing and sharing records. If someone in the audience is directly from a transplant group, please speak up. But yes, the young ones, yeah, it's a matter of the surgeon, how experienced the center is and how, but theoretically the babies, organs and systems that didn't have a 10-year experience of MMA is a healthier overall, but harder to manage in terms of calories, support, IV access, G-tube, all this other hardship, yeah. No perfect scenario, I'm afraid. Even with our experimental therapies, there's not going to be a magic wand that will fix the brain, especially the brain manifestations. Yeah.
Thank you. Any other questions for Dr. Manoli before we go? We're coming up on the half hour here. Well, thank you very much again, Dr. Manoli, for joining us, presenting today. It was a pleasure. And everyone else, stay tuned. Next week, again, Dr. Venditti is going to be with us. And everybody enjoy your weekend. Thank you, Dr. Manoli.
Thank you. Have a good day.
Bye.
Bye.